Unified conferencing.
To blended clinic forms. Can you unmute your mic to make sure that I can hear you?
Sorry about that.
Can you hear us now?
Yep, we should be all set.
All right. Thank you so much.
I see.
Well, hopefully.
We need to pull that thing, Emma. saying? Do you want us to help shoot so you can get in here? We could do that.
We're
Okay.
not even registered.
Okay, so you. Me. Me. What did I give you? You.
If it'll kill HIV, it should kill TB, right?
Absolutely. And follow visit record. I only got one of those. It's okay. We probably won't even need that. Okay. I think. Put this between us. Are we on? I don't know what to do here. Oh, it's there. Okay. You're supposed to sing "Oh wee oh." No, maybe not.
What? Hello?
It's just you look like well, you're not small like them, but the dwarfs how they would go "Oh wee."
That's my favorite movie.
Right? Okay, everybody knows that song.
Absolutely. Dorothy.
What can we hear? That looks like Winchester. It's me. All by myself. Don't wanna live. All by myself. Y'all making fun of me, aren't you? There's Janelle. Well, it's not working. Not working.
Good morning, everybody. It's 10:01, and I do want to respect everybody's time so we can get started. And as we get started, please, it would be great if you can all mute your mics. So that would less interference, and you can hear us. Please mute your mics. Thank you. Okay, welcome. And welcome to our Polycom training, updates to the blended clinic forms. And I'm just going to go through a quick overview of what to expect for this morning. We have a packed morning, and as you can see from our agenda, and as we go through, we'll let people introduce themselves. Up here in So a quick overview. I'll do the introduction and the rationale myself and Janine Hussel. Dr. Ann Williams from Norfolk would go over the revised clinic visit record forms. Debbie Diamond and Adela from Alexandra would go over the sample form documentation. Tracy and Janine Calhoun will go over the frequently asked questions. We also have other items that we want to review with you today. The sub-program coding, our own Lisa Parks would do that for you. The referral cards, Cameron Rose from Office of EPI would be reviewing that. And then the completion of the 900 CTR forms, Chantel Roy from Office of EPI would be reviewing that. So we have a whole morning packed. So just a little bit of a background, just for some of you who've joined us later on. It's always good to understand the background to see where we are and where we plan to move forward with. Back in July 2017, we had the STI billing. The STI billing was a joint collaborative effort between CHS office and EPI and the local health district. We had to start billing, and this was mandated from our sponsors from CDC because we realized nationwide more people have insurance, and as we have diminishing resources, we need to also bill when we can for our clients that have insurance. Once we started billing, we realized that, our STI forms needed to be updated to support our billing practices. So we implemented the new STI forms January 2018, and then we went on a road trip to make sure that clinicians, nurses were up to date with how to bill and code. And we heard from you. We heard that it would be easier and to provide holistic care if we could combine the forms together, STI and family planning. So we went on a new venture to come up with STI and family planning forms. Those were implemented in August 2019. And once we implemented those forms, gosh, did we hear back from you? So based on the feedback we heard from you, our work group reconvened to see how can we make these forms user-friendly. And so today we're back to go over the updates based on the feedback and also just reviewing the forms after it's been used for a while to see how we can make it user-friendly, how can it merge with your clinic flow. So, oops. Uh-oh. That's weird.
It's not showing the.
That's okay.
Supposed to be saying all
It's supposed to be, yeah. So, well, as I said, the rationale, which I explained a few minutes ago, we wanted to replace STI and family forms with a new form, which would provide holistic approach to sexual health and reproductive health. We wanted forms, so please look at your own slides that we've sent to you. We wanted forms to reflect the current billing, current screening recommendation, best practices, billing requirements, and also to facilitate quality assurance activities. So, as I said, we reviewed feedback we received from the nurses and clinicians, and this morning we're going to review the updates to the blended STI and family planning forms. So this is the work group. As I said, this was really a collaboration between CHS, Office of EPI, Office of Family Health, and the district. So from CHS, myself, Janine Hussel, who's the Director of Nursing, was involved, Lisa Parks, and Juanita Leon, the healthcare reimbursement, and River from Office of EPI. So we have to say a big thank you to River. So she was the graphic design behind all these forms. Valencia for always getting us our rooms, getting all the technical, and she was here early this morning getting us ready. Janelle for giving us the expertise from family planning, reminding us what Title 10 wants us to, counseling requirements, things, that's outdated, and how to keep current. Janine Calhoun just joined us. We thank you for your participation. And from the district, we really have to say a big thank you to Dr. Ann Williams. She will be presenting this perspective from the clinician. So we wanted the people who would present this morning at people in the districts who are using the forms, who have been very successful with the forms, so they can give you feedback and they can review their own best practices, how it's been used in their clinic. So we thank you, Dr. Williams, Dr. Melissa Verre, Dolores Baldwin from Norfolk, Claire Ruday, STI experts from Thomas Jefferson, Debbie Diamond, and Adela from Alexandria. They will be presenting this morning, and our own Tracy Avery Jeter from Richmond, so she will also be presenting this morning. So as you can see, it was really a joint effort. We heard from you, and based on your responses, we are reviewing those this morning. Next slide. So the feedback we heard from you was that the forms, too many forms, the forms were too long. Well, our response is it's required to support our billing, difficult to know which forms to use. So, to make it a little bit easier, we've created a one-page summary for all the forms. We also heard flow of forms does not match the clinic flow. So we've rearranged certain sections of the clinic record to match your clinic flow. Forms difficult to complete and they're confusing. So we've added some coding and completion hints within the forms. We also heard uncertain how to use these forms in different scenarios. So we've created samples of completed forms with documentations. So there are also other comments, and the best way to really help with that is to develop frequently asked questions. So on this site, on our internal website, you can review all the feedback and the responses. And next, I'll let Janine give us an update on the electronic health records.
So the electronic health record is still in the budget. So we're hoping that it's moving forward. It looks like it is. We're already making plans for it moving forward. Anytime you adopt something like an electronic health record, it's not going to be a quick process because we're upgrading bandwidth first and infrastructure. But while that's happening, we're really working to identify and confirm a vendor and how and what we'll have to do with that vendor to move forward, because it is going to mean some mapping out of our processes and making sure that we're Title X compliant so we can get all the data we need for Title X. So the good news is we're still moving forward. I am still hopeful. If it hasn't been zapped by this point in time, it usually moves forward. So that's where we are at the moment.
Thank you, Janine. So Dr. Ann Williams will give you the floor to please review the revised clinic visit record forms.
Me?
Yes.
Yes.
Yes. It's,
Oh,
yes,
thank you.
Yeah, thank you.
Thank you. So your first slide is a summary of 4 of the 8 forms that we created for the combined family planning and STI clinics. Your basic instructions are expanded upon in the instructions for each form. Today we're going to focus mostly on the visit health history and the follow-up form. The forms have been revised to try and support billing. You'll remember from our Polycom on documentation and billing, there are certain elements that are required. The forms have been revised to make it more user-friendly for the clinician to enter and check required elements, and also for the nurse or other staff member who has to complete the review of systems to more easily accomplish that. So the visit health record is for every visit except the follow-up visits. You have instructions in your packet from the previous Polycom on that. The clinic visit record is really the main visit record, and this would be the audit tool to assess that all of the required elements are entered for the visit. The follow-up visit form, which we have retitled Follow-up Visit Clinician Order Record, will be very useful for follow-up and return visits. So the new and final clinic visit record, page 1, has been consolidated. If we could go to page 1. The sections have been rearranged so that the elements of the history includes actually 4 components: the chief complaint, the history of the present illness, the review of systems, and the past family and social history. All of those elements have to be included if you're going to code at the detailed visit level, which is the 99213. And so you see how we eclipsed items from page 2 of the previous form to page 1. We lowered the visit date so that it would not interfere with entry into the chart. The descriptive elements are the same, and the space left for notes is the same. We listed current medications and age on this form, and we also brought constitutional from page 2 to page 1. The review of systems, it's very important to note that this only needs to be done when the provider will see the client, that is, when there is a complaint. This can be completed by the public health nurse, but the clinician can also designate the healthcare technician or other staff to complete that as long as they review it and attest that it is accurate. On the bottom half, you have a section for the interpreter or anyone else used for assistive services. The name, title, and number of that individual is at the bottom left. Then on page 2, we have revised this so that it is only to be used by the clinician. So when it is a screening visit that is testing only without symptoms, this form does not have to be completed. We brought back the diagrams. Some of the providers were eager to be able to demonstrate their findings, so the diagrams are back. We have the various organ systems, and you are to enter using documentation by exception. If you check that it is normal, on pages 2, 3, and 4 of your instructions, there is a description of what is included in a normal exam for that system. So I would encourage you to read those. At the bottom, there is a space for microscopy results, and then at the bottom, the assessment and plan. The third page, again, from page 2, we place the past medical, family, and social history to the top left. You'll see in the counseling and instruction sections that the boxes marked with an X are those required to meet the Title 10 requirements. You are to initial to the right and check the box for any counseling that you accomplished. We included medication orders and vaccination orders together a little lower on the page so that these are combined. And in the medication orders, we eliminated some of the medications. Originally, there were 8 entries, and now we have limited to 1, 2, 3, 4, 5, 6. We also combined administered and delivered and allowed you to make initials. So we kind of collapsed this to make it a little bit easier. The clinician signature and the public health nurse signature go down at the bottom. So this form has been abbreviated to some extent, made more user-friendly, and easier for the public health nurse and the clinician to use. You will have examples of scenarios where this form is used, and I think you'll find it very helpful. The next form that we revised was the follow-up visit record. Again, we renamed it follow-up visit / clinician order record so that you would know that this could be used for physicians to enter orders for treatment or other follow-up. And the nurse would execute that order upon the client's arrival to the clinic. At the top left of the form, we now have reason for return instead of reason for visit. That is on the top left. We included review of systems in the mid portion, along with a section for examination, so that we added some systems from the old form. The old form actually only had 9 systems. This one is expanded to include 12. And there is a small section for exam notes. On this form also at the bottom, in the section for medications and instructions, we modified this so that the medicines used to treat reportable diseases are listed. We listed metronidazole only once so that you can make your entry as to whether you were delivering a 7-day course or a one-time course. We deleted gentamicin. All of the districts were not using gentamicin, but of course we left space for other where that can be entered if it's required. Also, in the middle, we changed method. We collapsed that, so administered and delivered are simply indicated by letter and not by the entire word. The initials of the clinician or nurse administering or delivering is there, the lot number, and of course the expiration date and injection site. For this form, the clinician can actually enter the order, sign his name at the bottom, and date it. Then when the client returns, the nurse would use the visit date at the top. That's when that would be entered. And the nurse would sign and date for that date of service. We encourage you to write in the client's name and date of birth, and the OSS staff will then create a label and place it over it when the client arrives for the visit. These are the major summaries for these 2 new forms. These are the final forms, and we hope that we were able to respond to most district concerns. Thank you.
Thank you, Dr. Williams. And I'm sure you will leave questions for the end. And so we'll move right along with Debbie Diamond and Adela from Alexandria.
Greetings, everyone. I'm Debbie.
I'm Adela.
And we came up with a few different scenarios. Our first one is a woman who came in for screening. We named her Justine Okay. And on her clinic visit record, she is going to see a nurse, and a clinician is not needed. So you see up in the complaint, I put in quotes, I just wanted to get checked. This was not a new problem. This person was being checked. I put some notes to the right that she'd had unprotected sex 6 days ago and is nervous. And male to female, no gender affirming surgery. So Justine is trans, male to female. She's currently taking estrogen up on the right. You see her vitals are there. and she's in no apparent distress. LMP doesn't apply to this woman, and she's 48 years old. When she came in, based on her history, I did a few review of systems and found everything to be normal. Because of sites of exposure, we did genitourinary, lymphatic because of the high rate of syphilis in our area. We did mouth and throat assessments because of her having oral sex, rectal pain because she has receptive anal intercourse, and of course the genitourinary, she does both penetrative and receptive intercourse. Then page 2, I put a date on it, and I didn't hear back from an email, or I didn't see a response to my email. Are we able to take out page 2, or do we just date it and leave it blank?
We can take out page 2 because it's not, applicable in
It's
this
not
case.
part
It's
of
a
the
nurse-
visit.
Yes, it's a nurse-only visit.
Okay, perfect. This, so we can now pull a piece of paper out and throw it out. The next thing is going to be page 3. Under past medical family social history, I noted that she transitioned 20 years ago, or she identified as male to female 20 years ago, and she attends Women Walker Health for estrogen and support groups. We did risk reduction counseling. We discussed PrEP, Hep B, Hep C counseling, and she received condoms. If you go back to the front, her blood pressure is 136/89. So I gave her a blood pressure tracking card, and I referred her to Whitman Walker Health for continued blood pressure monitoring. Under the PrEP counseling, I put below that she had declined PrEP. In her assessment, we're testing all sites. She self-collected urine. I collected her throat specimen. She self-collected her rectal test. A syphilis test was drawn, and an HIV test was drawn. I think it's noted previously that she'd already been tested for hepatitis B and C. That would have been on her visit record. Bactrim is her allergy in color, that's in red. And then she was already vaccinated for both hepatitis A and hepatitis B. I signed and dated at the bottom of the record. We hope all of Justine's tests come out okay. I think Adela will do the next. Does anybody have any questions or anything? Are we opening this up?
We're saving to the end.
Okay.
Okay, so here we have, this would be a traditional, this patient could have arrived in family planning or STI, but we saw her as a family planning patient, Virginia Clusell. She arrived with a chief complaint of vaginal discharge. You can see the full HPI, including the location, duration, quality, etc. That she's complaining of this discharge for 2 weeks. She's noticed it to have a foul odor and be worse after her menses. She has no vaginitis history, and she has one current partner. They have been together for 3 months now. She uses Nexplanon as her birth control method, which was inserted last year. She takes a multivitamin. You can see her vitals are within normal limits. She's 24, and her LMP was roughly 2 weeks ago. Her review of system here includes some constitutional elements. She's not having nausea and vomiting. Under genitourinary, you can see that her last intercourse was, I should note this visit date was the 30th of January. You can see in the top corner, and she's an established patient. But her last intercourse was 4 days before this visit, and it was unprotected. She noted a feeling of irritation during intercourse, noted that her menses are irregular with Nexplanon, and the discharge that is expanded upon in the HPI. Both the nurse and the clinician, we both Debbie actually conducted this review of systems. You can see here the conducted, and then I, as the clinician, reviewed it. So continuing on to page 2. Given this patient's reason for visit and complaint, I could see that she was breathing easily, could walk, and was oriented to person, place, and time as a basic assessment. And then her expanded genitourinary assessment showed a moderate amount of milky white homogeneous discharge that did have an odor. I checked her next one on. It was easily palpable. And I performed microscopy, which showed a pH of 5 and 10 to 15 white blood cells per high-powered field, no trick, positive whiff, positive clue cells, no yeast. So looking at our assessment and plan here, because this is a family planning Title 10 appointment, we note her next one on. She's happy with her next one on, and we reassured her that that her bleeding pattern that she's having with it is normal. She was diagnosed with bacterial vaginosis based off of the exam and the wet mount. We discussed vulvovaginal health and hygiene. You can see some details there. She was given an option between topical versus PO metronidazole. She elected to use PO metronidazole. We gave her information about BV and answered her questions there. We also did some STI screening. She has sex vaginally and she performs oral sex, and so we collected extragenitally from her pharynx. She also did HIV and syphilis testing and accepted some condoms. She will return. She's due for a PAP. She will return for that in a couple months here. Flipping to the last page, you can see the counseling that was provided. We like to make a practice of referring just about everybody to our local federally qualified health center for their primary care provider if they don't already have one, and discuss the side effects of her meds. And when she's coming back, you can see the testing that was done noted under the lab test orders, including who collected it, where it was collected from. She received a few vaccines, or she received her flu vaccine today, and we noted that she completed her HPV and Hep B vaccination series, and she left with her metronidazole, which I initialed that I dispensed to her, and you can find our signatures at the bottom. We have a third scenario as well.
That's yours. No, we're following.
Oh, you're right. I'm sorry. We're following up with her. So we found, or when we received her results, that she unfortunately also had chlamydia in addition to her BV that was treated at the time of her visit. And so this is a way that we actually have two possible scenarios here.
We're going to do the second scenario later.
Okay, thank you. So in this instance, she comes back to clinic, is seen by the nurse and the provider. Do you want to? You took her back?
So the reason for her return was the positive CT labs, oral and vaginal sites. We did her vitals. They're up there on the top. In no apparent distress. We noted no changes in her medical history. Next one on, and vitamins or medications, no allergies. We reviewed systems. And from there, the clinician did some review and exam of systems.
So discussed how she's doing after her BV treatment. No exam is indicated since we are just treating the positive lab here. She does not have any allergies. And I prescribed the CDC recommended treatment for chlamydia.
So we did STI risk reduction. We reviewed the medication side effects, the return to care in 3 months, condoms. She declined. She'd gotten them the last visit. And we also did partner notification and arranged for her partner to come in for treatment. I administered the azithromycin. I circled A, my initials. I didn't write in the lot number. Sorry. And then I signed and dated.
So in our alternate...
No, we're not doing that yet.
Oh, okay.
Okay, then our next person that I think we have is Mr. Spyro Palladium. So he came in and was first seen by the nurse. He came in because his physician referred him for positive syphilis screening. He had no past testing or treatment history. On 1/15/20, his labs were RPR 1-1, TPA BIA positive, no signs and symptoms, no known exposures. We did his temp, heart rate, and blood pressure. He was well in his appearance, 32 years old, no medications. And again, because of it being a sexually transmitted infection and the sites and all that he identified as having been exposed, we did general constitutional, genitourinary assessment, review of systems, vision and eyes. We're looking for a possibility of neurosyphilis, same with the neurological psychiatric checks there, lymphadenopathy or rashes and sores for indication should it be primary or secondary syphilis. And again, rectal pain was assessed because he participates in receptive anal intercourse. Now you reviewed it.
Yeah, so Debbie conducted that review of systems, and I reviewed it before going into the patient's room. So after reviewing, and I entered the room and did the exam, as you can see here, checking the oral cavity. We did a full assessment of the skin and a genitourinary exam here, which was all benign. So this patient was diagnosed with late latent syphilis and was prescribed bicillin weekly ×3. We discussed this diagnosis, discussed the partner notification, discussed possible sequelae, discussed warning signs and symptoms. The patient was linked to DIS for contact investigations and received condoms. We did other STI screening today, which we'll see on the next page, and said the patient will return in a week for the second bicillin.
So during both the initial visit history and general history review, we also did some counseling and education as when we went back in for treatment, noting that he was in a steady relationship, but he does have some outside partners. We did do STI risk reduction, PrEP counseling, Hep B, condoms are given. The DIS was going to reach out to the for testing of partners just to be sure that we didn't have some sort of an incubating infection, to verify that this was a late latent. After giving the bicillin that was ordered down at the bottom, I administered it, I reviewed the side effects, and the return appointment was made for the next week. We also, when we give our first shot of bicillin, we repeat the syphilis test, and then we collected specimens for urine, throat, and rectal gonorrhea and chlamydia, signed and dated at the bottom. So Spyro came back the next week, a week later, for his second bicillin. Again, we did the constitutional measurements. No changes in his medical history, still no medications, no known drug allergies. Review of systems, we went back over any changes in constitutional, genitourinary, or lymphatic. He tolerated the bicillin number 1 with minimal pain, and his partner's results were negative. We reviewed risk reduction, medication side effects, return to care, and condoms. ADLA, I wrote in number 2, bicillin 1.2 ×2. I crossed out the weekly dose, circled administered, my initials, lot number, expiration date, and where I gave it. Signed and dated.
And we'll expect to see Spyro back in a week for his third bicillin. So in the use of the follow-up form, also the clinician order record, we have the option now to use this to give to write orders that can then be carried out after the order is written. So you can see in the alternate follow-up for Virginia here, the lab was received that she had chlamydia, and I got the chart and wrote the reason for return as being she had positive chlamydia vaginally and pharyngeally, and and then I ordered the medication at the bottom. I signed and dated the bottom, and then this form is ready for her to come in and be seen by a nurse for administration of treatment.
So she came in, again, we did the constitutional measurements, no change in medical history. She's got Nexplanon and multivitamins, no known drug allergies. Her discharge improved after her BV treatment. We're assessing her throat and genital urinary assessment because of the positive chlamydia. The counseling and education is STI, HIV risk reduction, side effects, care instructions, condoms, and partner referral to bring her partner in for testing and treatment. Then down below you see I administered, initialed, remember to write the lot number down this time, and the expiration date, and then I signed and dated. Adela wrote the order on the 5th. I administered the medication on the 6th. And that's the end of our examples. Do we have questions?
This is Rhonda in New River. Can you hear me okay?
Yes, we can hear you.
Yeah, so I actually have a couple questions. One thing is, so do we not have a complete med list anymore? Or are we just keeping up with the current meds on these forms?
We also have a med list.
Okay, so we're double documenting on the med list and then on their visit forms.
As far as I understand, that hasn't changed.
Okay, that was one question. And then my other question is, to me, I'm having trouble when the patient actually comes in that day and I, as a clinician, order the medicine and the nurse administers it and dates it. That's very clear to me. But when I write an order on a date that isn't the date that they give it, that seems really hard for me to decipher which was the date the order was written and which was the date the nurse gave it. Can you just go through that one more time to clarify that, please?
Well, on the Virginia Clouseau, her return visit, Adla had checked the azithromycin, initialed, and put the date after her initials. And then she also signed and dated at the bottom of signatures. I know they're awful small in a printed version off of the handouts. We didn't do that, and maybe there's some recommendations to improve how we documented the follow-up visit for the bicillin. The order was written on the first visit, and I didn't make a note. Normally, I would write a note, refer to order on X date, and I probably should have done that in the additional comment section when I gave the bicillin number 2. Would people agree with that?
And so in the original bicillin order, on this particular one, it also looks double documented, where you've written the order for the bicillin and the assessment plan, and then it looks like the clinicians also marked they've written the order under the medication order, so that also looks like double documentation. Is that correct?
Yeah, that's correct. My understanding was that it is not required to document the order of medication under the ANP. I personally tend to do that because that's how my brain works, and having it in one place as I'm writing that out, but I think that double documentation is not needed. I think where it is required is under the medication orders, because that's where you are ordering the medication.
Okay, and then would you as clinician go ahead and include that bicillin on the med list for the one, for each dose that you've given?
Yes,
one time only?
What I would do is on the med list being just a snapshot of the medications that the patient is either currently on or has been on in the past. At the time that I ordered it, I would write the bicillin, 2.4 MIU times IM times 3 as a snapshot, again, not as an order on her med list.
Okay, thank you.
This is Dr. Taylor from Chesapeake. Hello?
Yep.
Okay, thank you. Sorry. So my question is, I noticed that you used the follow-up form and that the clinician placed the order on the form and dated the form the day prior to the visit. But is it still an option to use the progress notes for me to write my order? Because otherwise it could look as if I've reviewed the information above, ordered it on the date that the client actually came. So we've been using progress notes for the follow-up visits. That was what we were instructed we could potentially do versus follow-up visit record note. Depending on the client's situation, we make a choice between the two. But I'm wondering if that is still the option. Because I think as a clinician, I would be far more comfortable to write my order at the date and time with the information that I have.
I would defer part of that question to Dr. Adekoya, but my understanding is that the idea here is to use this follow-up visit and clinician order record to have everything in one place. As we have more forms, there's meant to be less flipping through charts. And so the way that I felt comfortable with writing an order prior to the administration of that order was to initial and date next to it. You can see on the visit for Virginia dated the 6th, where next to the azithromycin order, I've initialed and dated there.
Yeah, and I see that. It's just, to me, you document on the time and the date that you have the information. So that's why I was wondering for clarification in regards to that.
Yeah, Dr. Adekoya, do you want to step in?
Yes, I was just going to jump in. I think just for clarification, and Dr. Taylor, that's why we're going through it. It's been vetted. You're safe. You're not going to be penalized, or we've gone through it. So you can write the order, as she said, on the 5th, and then the azithromycin can be given on the 6th. So we've reviewed it from the nursing perspective, from the clinician perspective. It's just easier to have everything in one page. So if ever you've been audited, everything is in one page. So I know it's a little bit uncomfortable to start off, but that's why we're going through these scenarios, show you how you can use the forms, and that if your concern is liability, this has been really vetted back and forth. As long as you document your initial with your order, liability-wise, you are safe. It's in accordance with medical record keeping.
Also, Dr. Adekoya, this is Dr. Williams in Norfolk. The way we discuss the form, the visit date at the top will indicate the activities conducted on that date, whereas your signature date at the bottom only reflects the date that you entered the order for medication. So your signature and date at the bottom does not signal any activity above the providing the order.
Yes.
And
Thank you,
that's why
Dr.
we
Williams.
allow for two different ones. We also have another question from Norfolk from our super user.
Hi. My question was that when you have the bicillin order, you have weekly doses. And so on that first dose that is given, the nurse will go ahead and sign her initials, a lot, and expiration date. Where would the second and third dose be documented?
I documented the second dose on the follow-up visit form. I put a number 2 outside what I administered. And you see up at the top, the reason for the visit is bicillin number 2. Normally, and I didn't on this page, I probably should have written on the bottom, usually in the assessment plan, I write see medication order 130 to refer back to the original order for the bicillin times 3.
So you would be using a separate sheet for the second order,
Yes.
correct?
Yes.
I mean, second
A follow-up
dose.
visit. Mm-hmm.
Okay.
This is Leah at Lord Fairfax. I have two questions. The first question was on the visit record that's 3 pages and the clinician's not here, so they're only seeing a nurse, and it was recommended that we could not utilize the second page. Would that not be a liability when on the bottom it says page 1 of 3 and then we don't have a
maybe.
page 2 of 3?
It's a good point.
And
We just thought to save paper, not to put page 2. But if you want to put page 2 in, just put a line through it. That's fine. But I don't
okay,
think...
I'm just thinking if it were ever to go to court, it would look like we're missing documentation.
Okay, all right. Okay, I mean, that's why we haven't...
Sure. And then
Right.
my second,
Yeah. What? Excuse me. I'm hearing from Riva saying that we, in our instruction, it says that we don't have to put page 2 if it's a nurse-only visit. So we're covered. You don't have to put page 2. It's written in our instruction. So if we ever have to go to court, we have a reason why we don't have page 2. It's a nurse-only visit.
okay. Okay, and then my next question was on the follow-up visit for spiropallidium, we write, it's written in the chart that his partner's results are negative. Is that, I mean, we've never written about partner's results in a client's chart.
That relates to the diagnosis. If the partner were positive and treated as an early latent, it could impact the stage of syphilis of the actual patient. We don't use a patient's name or the partner's name, but we refer to how that partner tested and whether that had an impact on the primary patient's diagnosis. Because you're going to be diagnosing on signs and symptoms, titer, history, and treatment, and then a known exposure.
True, but we usually don't refer back to a partner per se in the actual patient's notes. I mean, we do get the partner's information and we treat according to what the partner's information or results are, but we usually don't specifically refer to by saying the partner is negative. Like, we don't have that confirmation in that patient's chart.
So how are you reflecting your knowledge of that aspect of the assessment?
Well, so I'll leave that open to our nurse practitioner, Marion, to help me on that one. So, Marion, since we don't write that the patient's partner was negative, how do you reflect in that patient's chart that what they need or don't need?
I mean, I guess you'd refer to the patient's first or partner's chart or something, but I'm not sure.
If you need to say something that's contrary to what I wrote.
Okay, we have some experts here in central office that can share some light to that. So I'll let Janine Canhu.
I'm just saying, I think people are getting hung up on people's personal documentation styles. They're just examples. It's not saying that you have to do everything that was done on these samples. It's just to help you. So if you don't put the patient's partner's information, that's fine. That's just what they've done.
I think your concern is HIPAA. By HIPAA laws, as long as you don't put their name, their medical record number, you're fine. You can refer to a partner. You're not, by looking at that chart, I cannot infer who that partner was. There's no contact information of that partner. What you have to be careful of is not including any personal information of the partner. So if you just say the partner didn't have any signs and symptoms, there's nothing in that that identifies the partner HIPAA-wise. That's what we should be concerned about. You are safe. So that's,
I
I just
think
wanted
that if we-
to be clear.
I think if we
Thank
think about
you.
this the same way that we think about, we're treating someone as a contact to chlamydia, that's a reference to the partner as well, right? So there's no identifying information. It's just anything that is contributing to your assessment of the patient that's relevant to the patient on whose record we are documenting.
Okay. Thank you. Great questions. Really great questions. For the sake of time, I think we'll need to move on to that next section because we have 1 hour left. And if we do have time at the end, I would open up the floor to more questions. But I do want us to go through this presentation. Thank you, Adele and Debbie Diamond. That was awesome. So the next person would be Tracy and Jenny Calhoun. Who goes first? You go first? Okay, awesome.
Good morning, everyone. I'm Jenny Calhoun, and I am the nurse consultant for HIV, STD, and viral hepatitis and the Division of Disease Prevention in the Office of Epidemiology. I came to this group late. Previously, I spent 26 years at Henrico Health Department with different aspects of public health nursing, but always in the STI field, so it's near and dear to my heart. I appreciate all the hard work that this group has done, and I will say that I was still at the local district when they first came out, and I'm not going to lie, I rolled some eyes as well. But I've reflected on it, and I've been thinking about, since I've been a public health nurse, we've had a lot of changes. When I started, we had a front and a back visit record and felt like we were giving really good care. But we're actually able to offer so much more now than we used to. We have more labs available. We have more birth control options. We have more prevention options. So we need a good way to be able to document all of the hard work we're doing. And so I appreciate everything y'all are doing out at the local level and also all the things y'all are doing here at the central level. With that said, I've been tasked with reviewing some of the frequently asked questions, and I apologize. I know many of y'all do not like to be read to, but just to make sure we all hear the same thing at the same time, I am going to read to you. So we're going to start with the first one, and I will say this group really reviewed every single question that came in. So first one, when should the general health history form be completed? And so definitely at the patient's initial visit, and then after that, you'd want to review it and update it with the patient at least annually. Anyone who has completed the older version, anything that was pre-2019, they should be asked to complete the new version, even if it has been less than a year. So, and River's done a great job of putting everything together in the form summary list and also in the instructions. So those are there for you to use. And just a reminder, all patients should complete a new form every 3 years. The next one, slide 26, when should the visit health history form be completed? This one you'd also want to do at each visit for the patient, with the exception of the following. So if they're returning for either follow-up treatment, medication pickup, or any procedure-only visits. And again, if you have further questions on that, refer to the instructions or the cheat sheet. Someone wanted to know, why is the visit health history form so long? Why does it ask for information that is not relevant for family planning visits? So basically, this form is intended to capture the information necessary for both family planning and STI visits. Many of our districts have gone to the blended STI family planning, and even if you're still having separate clinics, we can't separate people's needs. The STI visits generally require more information than family planning. It didn't used to be that way. Family planning used to ask a lot more, so go family planning. However, the same questions are often relevant for both types of clients. The forms are intended to encourage staff to consider risk factors and needs outside of birth control during family planning visits, and conversely to consider family planning needs during STI visits. And I think often we'll find that the family planning client themselves may not have risk factors, but we never know what's going on with their partners. So that's a big reason we want to ask all of these questions. And in general, all patients should be offered all relevant services regardless of their type of visit whenever possible. What if the patient doesn't want to fill out all of the health history forms? Well, we're not going to force anybody to do anything, but we definitely want to encourage them. The more information we have, the better care and the more complete care we can give them. It may just help to present the forms as part of a change in clinic processes and explain the purpose of the forms. And then, of course, if the client needs help completing the forms, it's fine to ask them the questions, and then the nurse or another health department employee can finish those forms for them and walk them through the process. There is a question, is there a cheat sheet to interpret the Spanish version of the health history forms? No, but all the questions and responses are all listed in the same order on both versions of the form, so the English version can be used as a reference. Obviously, if there's any difficulty with translation or with communicating with the client, we definitely want to make appropriate use of our translation and interpreter services. This question has been asked since I started in the 90s. What is the difference between a new and established patient? Established patients are those that have been seen by a clinician in the practice within the last 3 years. A big caveat to that is that the client may have been seen by any clinician in any VDH health department in the past 3 years to meet this criterion. So sometimes you need to look in WebVision to see where else the client may have been. The type of previous clinic visit, family planning versus STI, is not relevant for determining the patient type. And a biggie is if the client has not had a face-to-face visit with a VDH employed clinician in the past 3 years, then they should be considered a new patient. If the client is an established patient coming in for STD screening only, what forms do they need to complete? So this patient should complete the visit health history for each visit, and they should also review the general health history with the nurse or any other appropriate staff during the visit. The visit health history is not required for follow-up visits for treatment, medication pickup, or procedures. When should the full clinic visit record form be completed? The clinic visit record should be completed for every clinic visit with the exception of specified follow-up visits, which would include ongoing treatment, monitoring of an existing condition, which may be documented on the relevant flow sheets like PrEP, depot, wart treatment, or return visits for treatment only. And for pill evaluation or problem visits, it may be appropriate to use either the full or follow-up clinic visit records depending on the scenario. And then the last one I'm going to go over is what about procedure-only visits? What forms should be used? For procedure-only visits, such as IUD insertion or removal, LARCs, and colposcopies, you only need to review the health history forms and then complete the appropriate procedure form. The clinic visit forms are only required if the procedure visit is expanded into a full clinician examination. So they show up for their procedure and it turns out they have some other issues going on, and so they end up needing to have a larger service. And one thing I forgot to say is Debbie and Adela, thank you so much for the samples that you did. Those were great, and I love the names. Now Tracy is going to review the rest of the frequently asked questions.
Good morning, everyone. This is Tracy Avery Jeter from Richmond City Health District. Just want to go over the next set of frequently asked questions. The next one says that the clinic visit record is too long with too many sections. Do we have to complete it all? The great part about that is no, you don't have to complete all those sections. You only have to complete the sections that are relevant to that client's visit. So based on how they present. Make sure that you review the systems that are pertinent to that visit, and keep in mind that we do use documentation by exception. So if it's left blank, then it's implied that that section was not done. The next question says there are too many descriptors requested for the chief complaint. And do we have to complete all of those? Let's wait till that changes. Okay. Do we have to complete all of those? Again, no, you don't have to complete all of those. You need to document those that support your client's complaint and also support billing. The descriptors that are given by the patient are the ones that you're going to document. Make sure that you look at the instructions for each form because it will give you more information about which descriptors are pertinent and what are the minimum number of descriptions to complete. The next question asks about, is it permissible for a healthcare technician to conduct the review of systems? I'm happy to say that that is a yes, that your healthcare technician can complete the review of systems for you. The clinician can delegate that service or that responsibility to the healthcare technician or to a nurse. The nurse cannot delegate that, keeping in mind that the clinician is responsible for any information that is listed in the review of systems and that they have to ensure the accuracy of that information. Next question. There's not enough room on the record to record all of the findings. Keep in mind that you can always use your exception record. There have been some more space that's been added, some reconfiguration of the forms so that you have more space, but always keep in mind that you can use the exception record if needed. The next question asks, if the patient only sees the nurse during the visit, which forms are needed or which ones are required? As we spoke before, pages 1 and 3 are required on the clinic visit record when it's a nurse-only visit. As far as page 2 is concerned, you can put an X across it indicating it wasn't used, or based on the instructions, as River mentioned, you can discard that page. Keep in mind that that follow-up record that we have, the follow-up and the clinician record, can be used by just the nurse or can be used by the clinician and the nurse. And I'm leaving you all to be able to read through these specifically, but we're just hitting the high points here. The next question says, why is the section of the clinician's assessment plan on the second page instead of at the end? As you can see, that's been kind of reorganized some so that everything in reference to the assessment is on the second page and everything that is responsibility of the clinicians is on the second page. The first and third pages can be completed by the nurse as well as by the provider or the clinician. Next question asks about test results. Is there a place to document the test results that are done in-house, such as the pregnancy test or an H&H, on the clinic record? And yes, there is an area. It's a small area under the lab test order section on the third page. You can also use the lab results flow sheet, which is an optional sheet that you can use to document and track those results over time. Next question. This question refers to the follow-up visit record and when it can be used. As we spoke before, the follow-up visit record can be used whenever there is a follow-up to an initial clinic visit. That can be used in the case where you're doing a treatment, monitoring or return treatment, or monitoring an existing problem like a pill refill or a NuvaRing refill. If the client does present and have a new complaint, then you do need to switch and use the full visit record. So whatever is being addressed or followed up from that initial clinic visit can be used on that follow-up visit form. And then also the clinician can write their order ahead of time using that clinician order record. The next question asks about the master problem list. Do we have a master problem list to use? I know in family planning we've used that in the past. This form is again at the discretion of each local health district if you want to use that form. Because we do have the medication record, that can be used to record some information about medications and treatments. But as far as a master problem list, that is at the discretion of each local health district. And my last question is, where can I get more information on completing these forms and the related best practices? The best place to look is going to be the instructions for each form. They are very detailed. Take some time to read through those, and they'll give you lots of direction on what to do and how to use the forms. And we'll also be recruiting and training super users. So if you're interested in becoming a super user, make sure you talk to someone in your health district. Thank you.
We can take some questions for Tracy and Janine. Jenny.
This is Tricia Van Hoy from Mount Rogers, and Dr. Shelton has had to step out, but she had a question in regards to the general health history, where the NAs are already populated in that medical questions section, and wondered if there would be any consideration to taking some of those out, especially like the ones with depression and autoimmune.
I'll answer that. As far as removing those, I don't know if there's been any discussion about removing them, but you can always put additional notes on the section that says office use only. I agree there's sometimes some additional information that you'd like to know about the family that is in this section that says NA, but feel free to use that office use only section to add any additional information.
Hi, I'm Denise. I'm one of the nurse practitioners at the Norfolk Health Department. And I was curious, on the follow-up visit clinician order record, can we chart the PrEP prescription pickup on that flow sheet? Maybe not.
Hey, this is Jenny. Yeah, we did say that you would want to use the PrEP one for initially, but then you can use the follow-up visit record for their subsequent medication pickups. But either one would be okay.
Okay, thank you very much.
This is Warren County Health Department. I have a question. The follow-up form, if we're using that for NuvaRing pickup or pill pickup, in case we shorted someone at their visit because of dates or whatever, how much of that form has to be filled out? And by that I mean temperature, their vitals. Do we need to do that, or can we just use it for the medication?
Paula, aren't you referring to this as just somebody that's just going to come in and pick up their meds? They don't necessarily need to see the clinician or a nurse. They just need to be handed their meds by a nurse, but not really assessed. Is that what you're referring to?
That's correct. Like they have an order for NuvaRings for the whole year, but they pick them up a box at a time.
And this, so if they're not seeing a nurse or a clinician, then there would be no form that's done. The order would be in the chart that it's been dispensed, but that's all you would do. You wouldn't need to use any of those forms. Is that what I'm sorry, I know you got to come back. Is that what you're asking?
That's definitely a valid answer to that question. Thank you.
Okay.
Can we just document that we did dispense it, though, somewhere, like an exception?
Well,
note?
somebody's got to pull it. So, yeah, that needs to be documented, whoever's pulling it. But if it's not a clinician or it's not a billable visit, right? You would only be billing for the medication if appropriate.
Correct.
So there would
Awesome.
be no documentation. Yeah.
Okay. Thank you.
You're welcome.
This is Central Virginia Health District. Our clinician had to step out, and she had a question about like coding for subprogramming. She had an example of a family planning patient coming in for STI services only. What subprogram should be used, the family planning or the STI?
You just jumped. You're perfect timing, because the next presentation is by our very own Lisa Pax. She's going to go through the subprogram coding. So just hang on for a minute.
Good morning, everyone. I think by now almost all of you have heard or seen this in some form or fashion in prior presentations or in technical assistance calls and various calls directly to me. But we thought it would be a good idea to go ahead and go cover this during this presentation. So hopefully everybody will hear the same message and be on the same page. So when you have an STI versus a family planning, how do you decide? The most important thing I can tell you to remember is the overall encounter subprogram, so meaning the one that it's set up under. The primary reason for that visit, that's the code you use. So why is the patient primarily there? And that's going to drive how you set up the encounter. Is it VD or is it family planning? For Title 10 elements done during an STI visit, you're going to use family planning as the secondary subprogram. So, for example, the patient comes in for STI services and you do some elements of family planning. On the encounter details screen, you're going to actually type in the FP subprogram code for your family planning counting code. So if the person comes in and you give them a pack of birth control pills or something along those lines, on your STI encounter, you would code that line FP, and then you would put in the counting code, FP Aura or whichever it is. You need to do that in order to get credit or count that as a family planning visit. So it's still technically an STI, overall our overarching subprogram, but it has elements of family planning. So you have to remember to code that secondary family planning subprogram. Oh, go back one more really quickly. A family planning patient returning for STI treatment, diagnosed at the family planning visit. So the patient comes in for family planning, and then you bring them back like what was it? Virginia Clousel came back. I think, is that right? Good. Okay. So in that scenario, you would code that encounter as family planning, and the overall subprogram when they come back for that treatment would be family planning. Go ahead, next one. Sorry. Sorry. Just for those of you who haven't seen it, because I have a lot of questions that say, well, there's not anywhere to put two subprograms. Well, it's right in the body of the encounter. So if you look here at this example, this is an STI encounter. It was set up initially as VD, STI. But if you look down at the bottom where I've marked that, you gave the person condoms and had some conversation about, you need to use condoms, whatever the case may be. You've documented that in the chart. You see that one line there is changed to FP subprogram, and then the FPMCON, that's indicates the family planning method that's currently used by that patient. And then that's how you account for that family planning element of an STI visit. Next slide. Why does it matter? This is really important. A lot of people don't understand, well, it's just an extra step, or what difference does it make? For family planning, the amount of Title X money your district gets is based on your family planning count. WebVision is designed to gather family planning Title X statistics, as you know. It has been for many years. One of the things that it looks at when it's looking for statistical counts of your family planning clients is that FP subprogram. The other thing that it looks for is the FP counting code, which you are all familiar with those. They're FP Aura, FP Depot, and so on and so forth. If you don't capture the family planning subprogram when it's appropriate and add one of those family planning method counting codes, your patient is not going to be counted, or that patient is not going to be counted in your family planning visit count. Okay, so again, it's important to use a counting code on every family planning encounter, or every encounter that has a family planning element to it. The fewer family planning patients that you see, the fewer Title X dollars, and eventually it trickles down and has a negative impact on your clinics and your staff. So that's why it matters. That's why so much effort and energy goes into having this conversation and preaching this over and over and over. It is very, very important. Next slide.
Hi, this is Debbie. In your explanation, I was able to find my own errors in documentation. If you go back to your Virginia Clousel examples, I had circled her coming back as an STI because of the chlamydia, when actually that should have been an FP visit. I should have also checked and initialed that I did the Title X counseling, and my encounter needs to include the family planning code of Z30, and then the secondary diagnosis would be the STI diagnosis. That way we have all the different pieces all consistent with both billing, and I have my family planning counting code on the encounter. That way it all fits together into all the different elements that we would able to achieve with an electronic medical record.
That's right. Thanks, Debbie, for pointing that out. That's actually an excellent learning lesson right there. So, everybody learns from their mistakes. This is It shouldn't be, but it's kind of a complicated thing on how to code family planning, not family planning. There's been varying opinions on that over the course of the last year, perhaps. But I believe we have consensus now, the way that we expect for it to be done, so that we have consistency in data reporting and collecting. And Janelle, did you want to say a little bit about the justification for coding that second visit or subsequent treatment visits under family planning?
Kind of like what you were saying. Really, it's going to impact your caseload, and so less clients, less money, and we're definitely not pushing to see as many patients as you can. We want quality, but we don't want you guys to short yourself. I often see. I was just at a district a few weeks ago, and they had about 416 clients that could have been counted as family planning but weren't. And so that's what we're trying to prevent. The other part of it is it's all sexual health. And if we're talking about blended clinics, we need to kind of get rid of the STI family planning. It's just sexual health, and it's good practice. And most times you guys are doing the work anyway. I see most often in the records that counseling is happening with STI clients, but then you're not coding it in WebVision, so you're not showing all of the work that you're actually doing. So that's kind of why we're pushing for this. And I apologize because I know I've been part of it. Like, we've had mixed messages, and we're trying to get it situated. So we definitely appreciate you guys' patience with us.
So Janelle, if you could speak to just one little scenario that I actually encountered last week at a training, and just elaborate so that it makes sense to everyone. So we have a patient that comes in for family planning. She has her annual exam. Syphilis testing is done, and it's determined some days later that her syphilis test is positive. We need to bring her back for treatment, and then of course she's going to need the subsequent treatments after that.
Right.
Can you explain to the group how it is that on those return visits, why it makes sense to code those visits also as family planning? What elements in that ongoing syphilis treatment would be considered family planning?
Sure. So anytime you have someone coming in and they have a positive STI, we want to, or we should, be trying to figure out if maybe there's something else going on. Just like if we have a client that's non-compliant with their birth control, it could be an issue of coercion. It could be an issue of trafficking. You're not going to know that if you're just getting them in, doing the treatment, and then sending them on their way. I had a client once who did have syphilis, and come to find out it was an abusive partner, and it was just a whole mess of things. But I wouldn't have known that if I just gave her bicillin and sent her on her way. So that's why we're pushing as well. These things, again, are really linked. It's all sexual health. It seems intimidating and daunting a lot of times, like, oh, it takes too much time to do this counseling. But it really is not anything like extra. Again, you guys a lot of times are doing the work and having the conversations. I don't think that you always realize that you're doing it. So we're just trying to have you make a concerted effort. You need to be talking about the reproductive life plan. You need to be screening for coercion. If it's a minor counseling, method effectiveness. All of these things affect someone's sexual health. So it's natural, and it's something I'm trying to find trainings to see if I can help show you guys a little bit more what it would look like when I do one-on-ones with you. I kind of go through scenarios, and most times you guys go, oh, okay, I get it. That makes sense. But I'm trying to find something for everyone. So just bear with me. But in the meantime, if you have questions, you can definitely reach out. I'm sorry, Megan.
Thanks, Janelle.
I'm trying.
That clears things up to a large extent. Thanks.
Yes, thank you, Lisa. I knew there was a question, so I wasn't sure if with the presentation we'll be able to answer that question, or if you want to, reread your question so that we can see if we can answer it.
Central Virginia.
Central Virginia?
It was answered. Thank you.
Thank you. Okay. Any more questions before we move on? We have 5 minutes for more. We can take a few more questions. We're doing well with time. Okay. Even though questions, we're gonna.
I'm sorry, this is
Actually-
Debbie. I do have a question. And this is something that I have confusion over myself. When somebody comes in with a chief complaint, other than screening or returning for treatment, like Virginia Clouseau, she had vaginal discharge. For billing purposes, are there a certain number of elements that I need to comment on related to that problem, related to, well, we do want to communicate as much information as we can, but also to meet billing purposes, the complexity of the visit and such?
So I'm vacillating with answering that question because what we don't want to happen is to say you have to do these things to create a billable visit. What we want you to do is go through and do the problem pertinent things, the things relative to that patient's complaint, without saying, and then do this, this, and this so that you can make it this kind of a visit. We don't really want to set ourselves up for that scenario. So it's really hard for me to tell you or to answer that question. But what I would say is just go through and make sure you're doing, now if they're going to be seeing a clinician, make sure your chief complaint is clearly documented. Make sure you're going through the pertinent reviews of systems, problem pertinent history. Just think in terms of problem pertinent. What's pertinent to that patient, that day, that complaint. And if you go through all that, and then of course the exam follows suit, you're going to just look at those areas relative to the patient's complaint, then you should be good. So again, it's hard for me to say do 5 of these or 3 of these. I don't want to steer you to say, well, that's not relevant, but they said we have to do 3 of these or 4 of these. That's just not a good practice. So again, I can't really give you a concise answer because of that. But if you document problem pertinent and areas all the way through from the visit to the health, to the history, to the exam, to your medical decision making, all of that, it's going to fall into where it belongs.
Yeah. And the way I would see it from a clinician's perspective is that somebody comes in, I want to know as much as possible as what's going on. My chief complaint, history of personnel, how long have you had this discharge, what's going on. Think of it, you're trying to solve a puzzle. So the more information you gather, the more you know about the client. And at the end of the day, you'll be able to say, well, when it comes to coding, but for the first few, your chief complaint and your history of present illness, you're just trying to solve the puzzle. That's the way I see it. So the more information you gather from your client, the better it is for you as you move and evaluate your client. That's the way I would say it.
I mean, just for example, like the one thing that comes to mind quickly, that's an easy thing, is that constitutional section. If you have 3 things marked in that constitutional section, even if you don't lay your hands on the patient and do any kind of examination, that's essentially a certain amount of points towards an examination. So just keep in mind that constitutional section is technically part of the examination. If you remember in the forms in a previous life, that section was in the exam section, in the clinical section, because it is technically part of the exam and how the exam gets counted. And now we moved it back for ease of clinic flow for all of you, but that's really part of the exam. So just keep that in mind. You're probably doing a lot more than you think you're doing.
If I can interject, Steve Richard from Henrico. I'm calling in remotely. I hope you can hear me.
Yes, we can.
Okay. I've had some technical difficulties, but and you guys touched on it for a minute. I would find it very helpful if the scenarios that went through from a clinical documentation standpoint were reviewed and coded, and we had feedback on the proper billing and coding for each of those encounters and the rationale behind them. I would find that much more instructive than the approach that we're taking to teaching coding, frankly. I find it that case-based scenarios with encounters and explaining why they should be coded as they are with the information provided would be very useful to me personally, if that is all possible. It was touched on earlier by one of the other clinicians about how they changed. They should have included counted it as an STI, but it was actually a family planning and needed a modifier, et cetera, et cetera.
Well, all right. Well, let me just kind of separate the things here. Whether something's family planning or STI is important to VDH from a programmatic standpoint, but really doesn't have anything to do with what CPT code is going to be used. So I just want to make sure that everyone understands those are different things.
Yeah.
The coding, the subprogram coding of an encounter is kind of not really relevant to the CPT coding of the overall visit. So it's a different thing. It's important to VDH for programmatic purposes, but not really relevant to
the CPT code.
Yeah, the CPT codes.
But it's two educational tracks for nurses and clinicians to look at how the coding occurs. And to me, if you took these scenarios you've given and went through from a coding perspective and stated how, I'm still not sure how these scenarios, clinically it makes all sense, everything that was done. But I would challenge that you get several different coding outcomes if you gave them to different clinicians and asked them to code it. I need to understand what coding is.
You bring up a really good point. If you remember, we've asked everybody to go out and try to audit some of their records and try to take a shot at coding them to get that initial baseline of practice. So that's a really great recommendation. And hopefully everyone out there has had this conversation at the district level to say, hey, let's try to code some of our records and see what we get. And then then when you get different results, talk through those. It's a really good learning lesson. I totally agree. Dr. Adekoya, you want to speak further on that?
Well, yeah. Well, I mean, I do agree with what has been said, and probably what we could do as a follow-up to this, because it's supposed to be an educative session. This was just to go over the forms. We didn't want it to include coding in it. The things that were discussed were program codes, family planning, STI, which programs do I use? It's separate from CPT coding, but as we're all learning, yes, as we're all learning, you can take it one step further. And please mark your dates. April 16th and 17th, I'm working on the Clinicians Conference. We're going to have an all-day session on clinical coding. So there's more to come, but I'm glad that we're having this discussion, because this would help us to be able to meet your needs. I'm glad that you brought it up. So definitely it's something that I've been working on, and I am planning a one-day, 8-hour session on clinical coding. So just hang on, it's coming.
Okay, thank you.
Yeah.
Mm-hmm. So this has been a great morning. We still have 2 more presenters to go. And for the sake of time, I'm going to let Cameron go ahead with his presentation. So if we have time at the end, we can take more questions. But I do want us to finish this. But this has been good. It's great that we're asking questions and learning what you need and how we can meet your needs.
All right. Good morning. My name is Cameron Rose. I'm the STD Grant Coordinator in the Office of Epidemiology. And I just wanted to provide a quick recap of our original patient to partner, also known as OP2P referral card pilot. So the OP2P pilot program was created to address the issue of DIS regularly encountering patients who either cannot or will not provide locating information for their partners. And these partners may remain unaware of their infection without any intervention. So the referral card program was designed as a patient-driven intervention to increase the number of partners that are tested and treated for STDs, because when the patient isn't reporting locating information for their partners, we're unable to follow up on those partners. So the OP2P card is currently being piloted at the Pittsylvania, Danville, Central Virginia, and Thomas Jefferson Health Districts. And we're anticipating that we're going to expand to a few additional sites in 2020. And I'll explain the process on the next slide. So this process starts with DIS at the OP2P pilot sites interviewing their patients And these patients might not be able to report partner locating information after a thorough interview has taken place and the DIS has made every attempt to elicit information on their patient's partners. So DIS will then distribute the OP2P cards and document the number of cards that they provide to their patient on the interview record. Then the patient is going to physically give their partner the OP2P card, or they can also take a picture of the card and they can send it to their partner through a text message, through an email, through social media, or through a dating application. And the partner is then going to use the card. There's a link for the VDH Health Department locator website. There's phone numbers for the health departments within each of the pilot districts. The partner is going to call the local health department that they would like to visit, and they're going to schedule an appointment if that department takes appointments, or they could attend walk-in clinic hours if those are offered by the health department. So on the day of the visit, the partner is going to present their OP2P card, or they could present a picture of this card at check-in. Billing and eligibility staff are going to code this as an OP2P, and they can just throw away or destroy the OP2P card if the partner has the physical copy. So this partner should receive chlamydia, gonorrhea, syphilis, and HIV testing at no charge to them. And I want to note the reason that I'm here speaking about this today is that these cards can be used at any local health department, even though we're piloting it right now only in 3 districts. Theoretically, the partner could come to any district in Virginia. And like I said, the encounter should be coded as OP2P, and the partner would receive the comprehensive STD and HIV testing. So this is an example of what our OP2P card looks like. So we have information on the website for the health department locator, and a note that many health departments are appointment only. And on the back, there are phone numbers for the local departments within the district. So this is an example of the referral matrix with the additional OP2P code. I'll also point out that partner referred, it's very similar to a partner referral in the way that you would treat it. The only difference is the presence or absence of this OP2P card. And then this slide is just showing the billing matrix that reflects the addition of the OP2P code. Next slide. And then any questions about this pilot can be directed to myself, Valencia McGee, or Juana Vasilou.
Cameron, if I may add just one point of clarification, this is the part. So these encounters will be sub-programmed with the VD sub-program. The OP2P code is actually going to be a procedure code or a data reporting code within that encounter. So I just didn't want, most of you all realize that, but I just wanted to make sure that we're clear on that. So it would be opened as a VD sub-program, and then just make sure that the OP2P counting code is somewhere on that encounter details, so that they can track statistical information and all of that.
Do you want to go back to the billing matrix slide? Dr. Adekoya asked that I point out also that these would be using the OEPI LabCorp requisition form, so they're being billed to Office of EPI. Do we want to do questions, or do we not have time?
Yeah, we have time for questions.
Okay. I can answer any questions now if anyone has them.
Okay, there are no questions for Cameron. We'll move to Chantal. Shatali, sorry.
Chaitali Roy. I'm the HIV CTR data manager, and this CTR form, many of you must have seen it. I just want to take a few minutes just to update you on the number of forms we received in 2019 from the health department. We got almost 46,000 forms from you, and from the STD clinic we got 20,000 forms, which almost comes to 43% of it. And from the family planning clinic, it's 14%. We received the forms from you. So I just want to make sure that this is the part 1 for all the HIV tests you will be doing. Please complete these forms and send it to us. And if you find a positive, can I go to the next slide? The other one. Yeah. This is the part 2. So for all the positives, prelim positive, please fill up this part 2 as well and send it to us. We'll really appreciate that. Thank you. Yeah, if you have any questions, please go ahead.
How much time do you have to return the form?
So we prefer that you send it to us in 15 days or in 30 days. And 25 forms in an envelope. The sooner we get, the better it is.
So it shouldn't be stuffed in medical record. Asking for a friend.
So each health department has their own process for how they house the CTR forms. Ideally, you don't want them in the medical record. You want them stored in a place that is easily accessible by anyone to include the lab result once it comes in, so that it can be sent to central office as soon as possible. So it's not the best practice to put them in the medical record, because out of sight, out of mind, which means that 2 years later, you're finding forms in the medical record. You're welcome.
Well, we still have time. I mean, I wanted us to go through with the presentation. So we have 20 minutes left for questions, and we can open up the floor again to your questions. We have the experts in the room, and those on Polycom land. So we'll let the questions, if you have any more questions, please let us know.
Good morning. This is Shannon here somewhere. Can you hear me okay?
Yes.
Okay. I have a coding question for Lisa, if you don't mind me asking. On Plan First, when we're seeing a family planning client and we do STD testing, we've been coding that STD testing as Z113, which Plan First will not pay for. What do you suggest I code the STD testing with for the Plan First?
You have to code with one of the Z30 codes. That's the only code that Plan First will cover. So when you can use a secondary code for the STI testing if you want to, but for Plan First, the Z30 series of codes are the only ones they recognize. So not only do you need to have it on your encounter in terms of getting paid for your clinical visit, but you also need to make sure that those Z30 series gets on your lab requisition as well. Because if a patient has Plan First and you expect that LabCorp is going to bill Medicaid for those labs, they are only going to get paid if you carry that Z30 series of diagnosis codes over to the LabCorp lab slip.
Okay, Lisa, I heard most of that, but I had a little bit of trouble understanding which Z30 code.
Which on what?
Which static? Oh no, static on my end. I hope you can hear me. Which Z30 code do I use for the STI testing?
I can't tell you which Z30 code. It depends on what you have documented in the record, because that's what you have to use. I can't, there's 15, 20 Z30 codes, Z30 something.
Yeah.
So whichever one most closely represents what you have documented in the chart, if there's no method involved and you strictly did, counseling, STI counseling, there's a code specific, not STI, contraceptive counseling, there's a code specific to just that counseling and other advice. Then you can use whichever Z30 code that is. So I can't really tell you which of the Z30s, you just need to select the one that most closely represents the visit.
Okay, thanks, Lisa.
Of course.
Hi, this is Mount Rogers Health District.
Go ahead, Mount Rogers. We hear you.
We have a question. If a patient presents just to pick up condoms, where do you want us to document that and how?
It doesn't need to be documented. If they're not seeing a nurse or clinician, it doesn't need to be documented. Not generating an encounter for that, are you?
Can you hear us? If they do see a nurse, is that something we can bill for? I mean, would you encourage that, or do we get credit, family planning credit for that?
If they're, after doing some kind of counseling for them, you're not just handing a pack of condoms, then you could document it. Now, whether you can bill or not is a different thing. I can't tell you that. I have to look at what you have in the chart. But potentially you could. But it would still be an encounterable thing. If they're seeing the nurse, there should be an encounter. And at the very least, you should have an encounter on there to indicate what was done.
Remember, for it to be a family planning encounter, they have to see a nurse or clinician face to face. So if they're picking up condoms from the OSS at the front desk, you can't encounter. But I think you guys too are kind of program encounters versus billing and coding. So like Lisa was saying, they're not the same thing.
Answer your question.
Yes. Second part of the question, if we do use it as a, family planning encounter billable with the nurse, what form would you like it on?
Follow up to a visit?
Right. I mean, are you saying someone just comes in, says they want condoms, and they see a nurse, the nurse counsels them and does...
Correct.
I would use the first or second page, I guess, or the first or third page of the clinic. Hey, that's for nurses.
That's a nurse visit.
Okay.
Hi, my name is Alicia. I'm a nurse at Norfolk Health Department. I had a couple of questions in regards to the forms. For the clinic visit record, when we were first presented with these forms and how to use them, for the nurse visit, we were instructed by the instructions that the review assistants did not have to be filled out if they're asymptomatic. Is that still current?
Yes.
Okay. And my second question is, if a client comes in for syphilis and they're diagnosed with latent syphilis and they're given 3 doses of Vicillin, if the first order is written by the clinician on the clinic visit form, are they also doing a new order each time they're coming in for each injection on the follow-up visit form, or is the nurse transcribing that order over to that form?
I think that depends on the clinician. I think it would be acceptable for them to write, if they write the 3 orders clinic visit, then the nurse on the follow-up should say per visit record on this date or per order. That would be fine, but they also would have the option to write one on the clinic visit, and then if they want to do the next one on the follow-up, that's the clinic choice, I think. Right.
Okay. Well, no, yeah, to be consistent, if the clinician has written pre-ordered that first clinic visit record, that should suffice.
Right. If for some reason they don't, they only write the one for whatever reason, then you would just do the other two on the follow-up form. They would need to write on the follow-up each time.
Okay. And also for clients that are coming in, being referred in for DIS patients, are DIS able to document in the medical records?
We're saying no. But I'm not the expert on this, but that my understanding is that the DIS are not supposed to document anything in the medical record. That's
Okay.
my understanding. Yes.
Okay.
All right. Thank you.
No more questions, Alicia.
I love you too.
We have another question from Norfolk.
Hi, my name is
Norfolk,
Regina.
this
I'm one
is
of
it.
We have a ton of questions. That's good, right?
That's
my
good.
name's Regina.
That's good.
I'm one of the clinic nurses. We were curious about the timeline for the electronic medical records and if we had a vendor, or are we looking at how many, I don't know. We just wanted a little bit more of an expansion on that very quick snippet earlier.
Okay.
You're kidding, right?
Regina.
I'll take a stab at that. What we do know right now is in the budget, and CHS has formed a group that we're working, to begin to develop a work group, and at least with everything that has to be done, we're looking to 2 to 3 years because it's a lot of work that has to be done. The bandwidth has to be built, the infrastructure, making sure that we have the right vendor that can meet all our public health needs. So we do want to make sure we just take one step at a time. We just go through it, and we have budget, and we need from you all process. It's a process because we want to make sure it works and it meets our needs. So in the meantime, we'll still have our paper records. So I would say on the best estimate, 2 to 3 years.
And as long as the money stays in the governor's budget, we fully expect to move forward with it.
Okay, thank you so much. So no vendor or anything, just
No.
we're still in the very
No.
basic planning. Okay, thank you.
Yes.
Yep.
We have 10 more minutes. We can take a few more questions.
There you go. There you go.
Okay, hello?
Yes, we can hear you.
Okay, hi, this is Christina. I'm of the Peninsula Health Department. I had a couple of questions. Comment basically. I wanted to know under the medication orders, if it was possible where it says contraceptive method, if that could be shortened. Some of the names for some of the medications are kind of long, and it doesn't look like there's enough room for those.
Okay. Is that on the clinic visit record?
Yeah, we can try to shorten it.
Shorten names.
Just some method. It's contraceptive method, right? So we can just make it method.
Yeah, I can make it shorter.
She says she can't.
Yeah,
Yeah.
we'll make it shorter. Sorry.
Okay.
Okay, thank you. My second question was there was a question earlier regarding DIS and whether or not they needed to document in the chart, and it was kind of hard to hear the response to that. Could you go back to that question?
What I want to make sure is I want to make sure we're right on that and the response. So can I get back with you on that? I'll send it by email. The issue with the DIS. We want to make sure we go through, make sure we're saying the right things to you. So if you can hold off for that, we would let you know the appropriate response for the DIS and documentation in the medical record. One thing we didn't discuss was the implementation date for these new forms. Based on this training today, we just probably have one or two things to tweak on the form that River would work on. So I was thinking once we've done all that, you can begin using the forms March 2nd. Once all that has been done, and we've gotten the response with the DIS, and then we expect everybody to be fully on board by April 2nd. Would that work out for you guys? We'll finish making sure there are no other edits that needs to be done. We'll post the forms. We'll give you time to order the forms. So we'll say by March 2nd, you can start using the forms so that everybody can be on board. And I know there's a lot going on right now with the coronavirus and with everything that has to be done. And then I expect by April 2nd for everybody to use these forms, by April 2nd. Sounds like a plan?
That sounds great.
Okay. So thank you all for all of you in the districts for your time, for those who participated with the presentation and the training. As you can see, it's a work in process. We're all learning and making revisions. We've heard from you to let you know that we do, understand we do read your feedbacks, and based on your feedback, we've made all these changes. And, it's a working process. If there are other issues that come up, bring back the group again to reconvene, because what we want to do is that we want to make sure the forms are user-friendly, they're meeting your needs. So please do not hesitate, send us your questions, and we'll make updates and revisions as necessary as we move towards, our final goal is electronic medical records. So before we get there, we still have to use paper. So to see how we can best use paper to meet your needs, the needs of the clients that you serve. And from the team up here, we just want to thank you for all you do, all the impact all the work that has been done to serve the citizens of Virginia. We really do appreciate you. We appreciate your time and taking out the time to be here this morning. So thank you all. And from the group here, we'll say have a great weekend.
Dr. Adekoya, this is Chesterfield. This is Chesterfield Health Department. We just had one quick question. You referenced the April 16th and 17th Clinicians Conference. And just for planning purposes, can you give us a little more information about that?
Okay. All right. So our first meeting is next week to work out the details on the 12th, but we have a tentative date of 16th and 17th for the clinicians training.
So save the date.
So save the date, 16th and 17th. So the 16th, I was going to have a full day for training on coding, because I've heard it, and based on this discussion today, I think we need more training hands-on. We're going to have a morning session and an afternoon session, and then in the evening, we're going to bring the next plan on. Merck has offered to provide a training for those who may need a refresher with Nexplanon, or those who are new to the agency and need training. Then on Friday, it's going to be a full agenda of different topics. We haven't finalized all the topics, but if you have any suggestions, this is a time to please send me your suggestions for topics that you would want to hear more about. Definitely would have updates on STI, updates on counseling session for family planning. We have some topics on maternity. I know some clinics still provide maternity care. And we have topics on PrEP. So it's still open right now. So please, I just thought this would be a gentle reminder, and I'll send out an email but this training on the 16th and 17th would be really directed towards clinicians that work in the clinics. So it's hands-on topics that can enhance the work that you do. So I'm glad that you brought that up.
Dr. Adekoya, this is Kathy Whitley at West Piedmont.
Yes, ma'am.
We also have a little minor tweak suggestion for the visit record on page 3 under the labs. There are three other blanks because hemoglobin is often a component, especially of a family planning clinic visit. Could one of those others be hemoglobin, hematocrit, whatever? I mean, we write it in there, but I think it would, stand out more if it was actually put there.
Okay. I mean, is that something we can do, Reva?
I don't care.
Janelle, do you have something to add?
Janelle has something to add.
That's fine, but I tell you, that's not a requirement for a Title X visit. So if I see that people are doing them just because, then it's going to be a finding. So it's on there, but that doesn't mean that it's expected to be done. It should be done when it's medically indicated.
Correct.
Okay.
Oh, can you tell us the location for the clinicians conference as well?
It's going to be, we're looking at Hyatt Hotel in Short Pump. And for those who live 2 hours or more, there will be hotel accommodations. So you can go shopping, you can go. We thought it would be nice to put you up in Short Pump areas. They have lots of shops, so if you like shopping like me, you'll have a ball. Any other questions? We have one more minute.
Dr. Adekoya, this is Melissa
ma'am.
from Colonial Heights.
Yes,
I was wondering on the visit health history that they fill out, every time. On the first page under section 2, if assigned female at birth, could we add a question there that asks when their last period was? I know it's on the visit record, but it would also be helpful here just so we can kind of look at it ahead of time.
We had that originally and we took it off.